The intervertebral discs appear to be the weakest links in the human spine. Being extremely subjected to compromising conditions related to compression, restricted movement, instability, trauma, overassessment and degeneration, they are the origin of different pathologies. The hernia showed in this model is merely an example of what can go wrong. Specific levels of our low back seem to be biomechanically more vulnerable and prone to develop discopathic disorders, sometimes aroused by what a patient would describe as a wrong movement or a blocking pain, or induced by microtraumata or degenerative processes. Pain hereby can be locally manifest or by compression on a nerve root descent in one or both legs, sometimes accompanied by aberrant sensitivity, decreased muscle strength and decreased reflexes. The therapy strategies should take in consideration the origin of the discopathy as well as the structural condition of the concerned disc, fully respecting all structural and functional features of its surrounding muscles and joints. However, the key role in their treatment remains undoubtedly decongestion, decompression, and regaining its shock-breaking function by restoring the joint play of its intervertebral partners and possibly decrease its extrusion. To do so by one abrupt cracking manipulation might turn out to be very risky, and instead of reducing the extruded disc material, possibly aggravate its effusion. A much more effective, safe and durable approach is offered by a series of repeated, gradual, specific and very localized, soft, manipulative mobilizations. Hereby, the Finnish Manitera device offers the best prospects as it can meet up with all the tri-dimensional movements we might be willing to introduce to the discopathic spine of our patient. In this case, the patient suffers from a right posterolateral disc protrusion L5S1, indenting the thecal sac, and clinically had little irradiation in his right leg with a positive straight leg raising test. After having treated concerned muscles with specific massage techniques and stretching, and having restored the function of one deficit sacroiliac joint, we start up with what we could define as helicoidal soft manipulative movements. Our Manitera device even enables us to do so under simultaneous axial traction, but applying this option depends mainly on the location of the extruded disc substance in relation to its neighboring nerve root. The starting position here is on the left side. The lumbosacral transition should be at the level of the flexion-extension spindle of our table. By positioning the patient slightly backwards, we take advantage of a supplementary centripetal force with a momentum equivalent to the distance from the concerning disc towards the spindle of the table. A cushion between the legs is to avoid strain on fibers of the iliolumbar ligament that might restrict the targeted mobilizations. An upper fixation belt mainly offers the patient feedback about whenever he might unwillingly or unconsciously change position, compromising the exact location and therewithin the effectiveness of the treatment. We deviate the lumbar spine to the left lateral bending as to open the right lower intervertebral disc spaces. By adding a backwards rotation component of the pelvis in respect also with what most authors prescribe, we are able to target our mobilizations to the focused level. During the mobilizations, in an average range of slight flexion and relative extension, we continuously adapt the rotation fixations depending on the eventual muscle responses. This treatment can even be administered fully tridimensional, if in some exceptional cases results might appear to be delayed. Without doubt, this method remains the best biomechanical conservative option to battle discopathic back pain and should, depending on each specific case, combined with attention to concerning facet joints and muscles.